Okay, the test wasn't great, so I wasn't overly happy with how you went in the test. Did you feel as though it was a hard test? When I wrote it, I thought I'd written a pretty easy one, really, but the results weren't as I thought they'd be. So on Wednesday, we're going to put aside at least half an hour in the practice session to go through the test. So I'll hand you back your exam scripts so you can sit down with them and go through them, and I'll try to explain to you how I marked them, what I was after in terms of the answers, and try and give you an idea of how to better answer the questions. I think a lot of you just wrote stuff that wasn't really looking at the question, and often students do that, get a bit excited, just write down a whole lot of stuff, but don't really look at the question and what it is I'm after. So I think part of it might have been you didn't understand, but at least some of it would have been I did a poor technique, didn't address the question properly. So it's important that you read the question, look for key words about what I'm after. So we'll go through it on Wednesday, it'll be a bit clearer. Now last time we met, did we finish the lecture off or was there a bit left over at the end? Who remembers? I can remember saying in the lecture, this isn't quite finished yet, you have to remind me, and you all went, yeah, 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 but you're not going to remind me, are you? Can you remember? Do you care? No. If you don't care, I'll just make sure it's on the exam. Simple as that. I held all the cards, remember. Do you recall if you got this far with it last time? Unless you speak to me and make some sort of noise, I don't know what you're saying. Don't put just mumbling under your breath. Did we finish this slide off? Okay, right. So we've got about as far as here. So with the Vibrios that cause gastroenteritis, there's three of them that are really important. Vibrio cholera, by miles and miles and miles, is the most important globally. But in other countries where cholera is not endemic, doesn't matter, really. I mean, we never see cholera in Australia. So if you didn't learn about cholera and you live in Australia, no one's going to care. It doesn't really matter that much. But these other Vibrios can cause disease in countries where cholera is not endemic. And the most classic one is Vibrio parahemolyticus. It's a cause of occasional sporadic diarrhea. It's not in the same way that you see endemics with cholera. Again, it's foodborne. So you see it mainly with fish products or anything that comes out of the ocean. These bugs are saltwater organisms. It's a really, really fast grower. The one thing which is difficult to me about this organism is there are so many subtypes and only some of them cause disease. So how do you know if you grow one, whether what you grow is a strain from the environment which is non-pathogen or whether you've grown a pathogen? And it's very hard to separate them unless you can do serotyping. However, sometimes I think that's an overstated argument. I think if you've got a patient who's symptomatic and you look in their stool for organisms that might cause disease and you grow one that might be a pathogen, it's not unreasonable to go, it's probably it. It might not be. It could be diarrhea from a virus and you just by happenstance grow a Vibrio parahemolyticus, but the chances are, if it's a possible pathogen and they have symptoms, it's not a bad situation to say it's probably the cause. You can do a test called the Kanagawa reaction, and what this is that strains that cause disease cause beta hemolysis on human red blood cells in the presence of salt. It's a bit long-winded. In other words, you make a mannitol salt plate and you add some human blood to it. If the strains are hemolytic, then they're probably pathogenic. If they're non-hemolytic, they're probably strains from the environment. It's probably a reasonably easy test to do, and it's cheaper than doing serotyping. This organism here, Vulnificus, is a really, really nasty organism. But again, it's not common in Australia. It's really common in the southern parts of Northern America. And it's linked especially to eating shellfish or being exposed to warm estuarine waters around those areas of the United States. So you can either acquire it by ingestion or by inoculation of a wound. So maybe you're in the water skiing, you cut yourself. That can be one method of exposure. But most classically, it's acquired by ingestion. Even though you inquire it by ingestion, you don't get diarrhoea. The bug is invasive, and you get short-term bacteremia that will progress rapidly to septicemia and whole body sepsis. About there. So this disease is systemic, and you see these people, especially if they've got underlying problems like liver disease, are really, really severely affected. And it goes from being you're sick to you're being dead in a couple of days. It's rapidly fulminant. So not a cause of gastro. You don't grow it from stool specimens, but it's important in the context of it's still foodborne as a common way of acquisition. And the last one is Eromonas. Whether you do or don't look for Eromonas in stool specimens is a bit debatable, but most labs these days don't bother. The reason being, lots of strains you find in stool do not cause disease, and it's very hard to make an association between the bug being there and it causing the symptoms, because it's commonly found in patients who are not unwell. You would hardly ever grow a Vibrio parapleticus from someone who's not well. But if you do surveys of healthy people and look for Eromonas, you find it quite a bit. So how do you make a link between that and a disease in a person that's got gastroenteritis? Eromonas are similar to Vibrios because they're oxidase positive, they grow well in salt, they look the same on a plate, big juicy colonies, strong beta hemolysis, but less of a requirement for salt than other Vibrios do. So it will grow without salt, whereas most Vibrios won't grow without at least some salt. But it's in the same overall family as Vibrios. So where I've worked recently, this bug's not been part of the routine screen for that reason. How about Vibrios and the laboratory? So the first thing is, there aren't many bugs you can screen for by direct microscopy of stool specimens, because most bugs that you find that cause gastroenteritis have the same morphology as normal flora. Salmonella, gram-negative rod. Shigella, gram-negative rod. So are all the E. coli in the stool. So is all the Bacteroides. All those normal bugs are the same morphology. So it's not very helpful. But Vibrio cholera is one of the few curved bacteria you see in the stool. So seeing them in the stool can be diagnostic depending on the context in which you see them. We want to be someone with the right kinds of symptoms. There's no point just seeing that in someone with a formed stool. So if their stool is like a cholera stool that is runny and quite clear, and you see curved rods, it's not a bad connection. Also with Vibrio cholera, you tend to have a much more of a predominance of the organism compared to what you would have with Salmonella. So with Salmonella, one every million cells might be a Salmonella. With Vibrio cholera disease, it would be a dominant part of your stool flora. If you want to culture for Vibrios, bear in mind that most labs don't have plates designed for Vibrio, because in Australia certainly it's not a common organism. So if all you're doing is culturing on standard media, which means MacConkey, XLD, things that are designed around growing Shigella and Salmonella, Vibrios look normal. Nothing about a Vibrio on a plate would say, look at me, I'm a pathogen. So if you're just culturing on normal media, you won't find them. So you need to have separate media designed for Vibrios. And that media is called TCBS. Thiosulfate, citrate, bile salts and sucrose. So thiosulfate, citrate and bile salts are all inhibitory. They're selective for Vibrio, and sucrose is differential. All Vibrios will grow on TCBS, but only those that can ferment sucrose go yellow, that's Vibrio cholera, and the others don't go yellow, they stay green. So the plate is green and fermentation makes them go yellow. So a yellow colony is possibly Vibrio cholera. So 98% plus of Vibrio choleras are sucrose positive. This is a bit like MSA with Staph aureus. It is possible for a Vibrio cholera to be a non-fermenter, but it's very unlikely. But there are other things that are sucrose positive besides Vibrio cholera. So the sucrose fermentation is a help, not a diagnostic feature by itself. If the agar is fresh, and by fresh I mean 2 weeks, maybe even a week, then non-Vibrios, including Aeromonas, will not grow. So it's very, very selective. The trouble is, most labs have media with a shelf life of up to 6 to 8 weeks. And if you follow that same principle and use TCBS when it's too old, it won't work. So TCBS has got to be done fresh, otherwise it becomes non-selective and you end up growing everything. If you grow a colony on TCBS, the first screen to help you say yes, it's a Vibrio, would be an oxidase test because they're oxidase positive. All Vibrios bar one are oxidase positive, and the one that's not oxidase positive, don't worry about it, it's unusual. You can do a string test. It's a simple little test you can do on a plate. And you use sodium hydroxycholate in the same way, in the same formulation as you use for the test for biosolubility. With this test, what you do is you take the colony, add some sodium hydroxycholate onto your plate and mix it. And a positive string test means when you pull the colony up, off you think you get this long bit of mucus. So we'll do it in the prac on Wednesday. It's not a bad test. It's not definitive, but again, a good screening test. If the bug is negative, it's most likely not Vibrio cholera. So, okay, I've got this string test and it's positive, oxidase positive, it's yellow. I'm pretty sure it's Vibrio cholera. And I go ahead and I do a multitof or I do an API and it comes out as Vibrio cholera. What more do I want to know? I'm all happy with myself. I've grown Vibrio cholera. First time ever. Happy Larry. And I go to my boss and I say, hello, I've just grown Vibrio cholera. What's he going to say to me next? He's going to say, well done. He's going to say, don't believe you. What's he going to say? Something else you want to know. Exactly. What's the serotype? Because only serotype 01 regularly has the toxin, or 0139. So you must serotype them. It's really important. There are no simple tests to prove whether a strain does or doesn't have the toxin. So serotyping is a de facto way of saying this probably has the toxin or probably hasn't got the toxin. And you want to know because disease with Vibrio cholera that's non-toxigenic is a mild form of diarrhea, but with the toxin, it's really rapid diarrhea and is much more dangerous in terms of being spread around the community. If you do any test with Vibrios that involve growth in broth, so like an API strip or other tests that involve growth, you must supplement the media with sodium chloride. The good thing is, how easy do you think it would be to make all the media contain some salt? Or the reverse question, how hard is it to make media with no salt? It's almost impossible because everything you put in media has salt to the level of being physiological saline. So everything you make in the lab basically has enough salt to grow Vibrios, apart from distilled water. So most media has enough salt. But if you're doing an API strip, don't make up your inoculum with water. You should always use saline anyway. The best diluent to use for anything used as a suspension is saline. Why would you want to use water? What's bad about putting bugs in water? Think transfusion, think hematology. It's hypotonic and they'll explode. Yes? Right. So today we're going to cover a few more organisms. Oh, am I recording? Yep, still recording. going to go over Campylobacter, look a little bit at E. coli, a bit at Yersinia, and then quite a bit of time on Clostridium difficile, which is really important. So Campylobacters, these are bugs that are microaerophilic and capnophilic. So they need extra CO2, which means they're capnophilic, and they need a large decrease in the amount of oxygen available. Now, if you use a candle jar tends to make the atmosphere have raised CO2, but only drops down the amount of oxygen by a little bit because the candle just goes out. So a candle jar is okay, but not perfect. So overall, you want less oxygen than you can get by a candle jar, but certainly more CO2. These are gram-negative rods, and they're curved, typically called seagull cells. So when you see them, they often look a bit like this, like a seagull, or like how kids draw seagulls. So they're curved. They're a similar shape, but thinner and smaller than a Vibrio. Always oxidase positive, good screen test. And the number of students in that little test that kept going on about doing oxidase test on a gram-positive coccus, I don't understand where it comes from. I can't think of a reason why I'd ever want to do an oxidase test on a gram-positive coccus. GPCs, catalase, GMBs, oxidase. It's a pretty simple formula, really. So of the Campylobacters, the one that's most commonly involved with human disease is called Campylobacter jejuni, subspecies jejuni. Because there are other subspecies of this particular species, it's written that way, but in reality, most times refer to the bug just as simply as C. jejuni, because the other subspecies are really unusual and found mainly in animals, not in humans. So if you say C. jejuni without specifying the subspecies, I know what you mean, that's reasonable. You also see in humans a couple of other species, coli in particular, and sometimes Upsaliensis, but they're much less common. So we hardly see them at all because we don't target these in our culture systems, but they can cause disease and they're important sometimes in some environments. You do get acute gastro. It's quite aggressive in terms of the diarrhea is nasty and the stomach cramping and there's bleeding. So you have blood in the stool. Because they're invasive at the local level, stomach cramping. It's a little bit like Shigella in terms of being locally invasive. I don't believe you can have this organism and be asymptomatic. There's no carrier state, but it's possible with everything like this, depending on who you are, how healthy you are, what the dose is, what else is going on, to have mild disease. It won't always be rampant, horrible diarrhea. It may be just mild diarrhea and you're still culture positive. And it may be after you recover from disease for 3 or 4 days, you may be asymptomatic and you're resolving, but still culture positive. That's not called a carrier state in the same way we see with Salmonella, which can be there for a long period of time, even though you're asymptomatic. There's a disease called Guillain-Barré syndrome where you have this paralysis of the limbs that ascends, starts off in the lower limbs, ascends up to the higher limbs, can last for a number of months and then goes away. It's an autoimmune disease. There's now strong evidence that prior infection with C. jejuni puts you at risk of Guillain-Barré syndrome. But there are other organisms besides that one. The curved nature of the organism is consistent even on solid media. So most times we always stress to you, oh, if this bug has this particular shape, it's more reliable from broth, not from a solid plate. But for Campylobacters, this is the shape from a gram stain off a plate. It's quite reliable. And similarly to Vibrios in stool, because their shape is so distinctive, if you do a gram stain of somebody's stool and they're acutely positive, you find them in the stool. So on this gram stain here, is that a Campylobacter? No, it's not. Is that one? Possibly is. Is that one? Certainly is. So seeing that in a stool specimen is diagnostic of Campylobacter. Why do you care? Well, you care because you can do that and get a result in half an hour, as opposed to culturing, which takes you a minimum of 48 hours. It's a slow grower. So I encourage people to do gram stains of the stool specimens if there's suspicion of Campylobacter. If you go to the website we used earlier in the semester and look at the data for Campylobacter versus Salmonella versus Shigella in Australia, this is by far the most common reported cause of gastroenteritis. Much, much more common than Salmonella and massively more common than Shigella. Shigella is relatively uncommon. Salmonella common, but Campy even more common. Why are these two organisms more common as causes of gastroenteritis than this one? He says, thinking, what a good exam question that would be. There's got to be a reason why one's more common than the other. Why do you see more of Salmonella and more of Campy and less of Shigella? What's that? No. Yeah. Both this and this are common organisms in animals in our food chain. This is only a human organism. You can only catch this from somebody else with Shigella. And that'll only happen if you do something that involves you coming in contact with their fecal material. Pretty unlikely, really, isn't it, for most people? Whereas with Campy and Salmonella, they're on food that we eat. We kill animals, they have these in their bowel, and then we eat the animals. Contamination is very, very likely, not hard at all. Even in a normal kitchen, without any sort of breakdown in systems of hygiene, these bugs are common in the environment, common on food that we eat. So they're common organisms. So for Campy, the biggest risk is birds and poultry. So at least half of the diseases can be linked straight back to some kind of poultry, either chicken meat or possibly eggs, but most commonly chicken meat. It's not uncommon to see 1 million organisms on a single chicken carcass. So take a whole chicken from Coles, put it into a bucket full of saline and rinse it all out, get all the stuff out of there, and then do a count on the saline that's there, 1 million Campylobacters. Not uncommon at all. It's a very common organism, and it's, I wouldn't say it's a normal flora in the chicken, and they live without it, but they often are colonised. If you have any chicken feces, 1 million per gram. Now most things, when you buy a chicken from the supermarket, it's free of chicken feces. But if you slaughter your own chicken at home, when you kill a chicken, what does it do? It shits itself. Well, it happens before you kill it because it says what's coming up. You see it with an axe and it goes, oh shit, I'm about to get killed. Off it goes. So these are common organisms. And what we do know is it's possible to keep your chickens free of Campylobacter if you house them in a way that avoids them coming into contact with poo from wild birds. That's the only possible benefit of having chickens kept inside, if there is one. And I'm not a big fan of chickens being kept inside, mind you. I think the risk is worth it to have them outside where they're happy. But it is important, and once one bird in the flock's got it, then they're all going to become positive pretty quickly. So even housed inside a warehouse, kept free of all the other outside birds, once one gets inside there, it's going to spread. So the biggest improvement in minimising Campylobacter is improved bird husbandry. The better you look after your birds in the flock of birds you're looking at keeping, the less chance of getting Campylobacter. So it's pretty important to look after them properly. So what can we do for culturing of Campylobacter? you can do direct microscopy. Now, if I said to you, please do a gram stain on every poo that comes in, it becomes pretty tedious. But what I've sort of had as a policy for myself is if the poo comes in and there's pus or blood, I do a gram stain. And I kept records of this for a couple of years when I used to work in the laboratory, and I found the PPV was very, very good. I never got a false positive. You look really carefully at the gram stain and you say to yourself, I want to see 3 or 4 individual convincing curved bacilli. And if I can see them and show somebody else and they say, yep, you're right, then I would phone the GP and say, probable Campylobacter, and never got one wrong. There were plenty of times that I didn't see them and they were culture positive. So as a test, it's got a very bad NPV. It's not sensitive, but it is very specific. So it's not a bad test to do if you want to try any previous service to your clinician, because it's quick. If you're culturing, it's different because the bug grows slowly. And you're trying to pull this bug out from an environment, fecal material, full of other organisms. So your plates must be very, very selective. So the plates for Campylobacter are not differential. The primary aim is to be selective. Now, with Salmonella, the culture approach is primarily differential. You try and grow your Salmonella in a way that makes the Salmonella look different than the other coliforms. With Campylobacter, the primary approach is to be selective. Everything else can't grow and your bug can grow. So you maintain an atmosphere of probably 5% oxygen. If you boil a candle jar, the candle jar brings down the oxygen from about 21%, which is the atmospheric air that we breathe in, to about 10-15%. So a candle jar gives you enough CO2, but still has too much oxygen. So it's not optimum. Campies will grow in a candle jar, but they grow better if you use a sachet designed for them to give the desired optimal mix of both oxygen and CO2. You can grow them at either 42 or 37. 42 is good because lots of other coliforms don't grow at 42. So this temperature makes your plate more selective. But the bug will grow at either temperature. And you want your plate to have other goodies as well to be enriching. So you use charcoal and or blood, plus a range of other supplements like ferrous sulfate and cysteine, things that are growth factors for Campylobacter. So overall, it's quite a demanding organism. And you want a range of things inside your plate, antibiotics. So you want things like colistin to inhibit most gram-negative organisms. You want some vancomycin to inhibit most gram-positive organisms. You want an antifungal drug to inhibit yeast from growing. Because what you want to have at the end is a plate with no growth unless you've got Campylobacter. It's got to be very, very selective. Now, there's a whole range of different kinds of media that you might see. There's one called Skyros agar, there's one called Buchler agar, and the one that we use in the lab I think is Kamali agar. You'll find this with most plates are selective. There's more than one possible culture medium you might use, depending on where you work. But these are all different formulations of the same thing. They're designed to be selective, and you'll find between this one and that one and that one, what differs may be the mix of antibiotics or the concentration of antibiotics, or whether they use blood or whether they use charcoal. But they're all sold commercially and they're all good media. When you grow them, it's important to think about, I'll grow this bug for 48 hours because they're slow growers. At 24 hours, there's almost no point checking your plate. If you've got a plate that you want to grow for 48 hours, and on the first morning after inoculation, you pull the plate out and have a look at it and check it just to be nosy, and then put it back in and re-incubate them. So compare this. Day 1, incubate. Look at day 2, re-incubate, and then day 3 you read the plate. Compare that to doing this, day 1, and don't look at day 2. That is enormously better. Because when you pull the bug out on this second day, just to be nosy and have a look, even if you're quick, you're pulling the bug out from a lovely warm environment or the right atmosphere, and you're putting it on the bench in the wrong atmosphere, in the wrong temperature, and they're not happy. When you put them back in and you incubate them, it might take them 6 or 7 hours to get happy again. So for one quick look, you've probably put that their growth by about 12 hours. It's not worth it. So you're better off doing that straight to day 3 before you open them. It isn't hard to do, and it makes a big difference in your growth. What you might find is, if were both positive, this would be that colony, and this would be that colony. Much bigger, much happier, and much more typical in its growth. So try and avoid looking too early. And I've got into a habit now of, after 48 hours, I read them and report them, and I put them back in for an extra 24 hours just in case. And about once every 3 or 4 months, I'll grow one at 72 hours that I missed at 48 hours. They are sometimes a little bit hard to get going, especially if I've seen the bug in direct microscopy. If I can't see it at 48 hours, rather than be wrong in my direct microscopy, I put them back in the incubator and go, please grow in this next 24 hours, and often they do grow. So most times, at least 48 hours, maybe 72 hours. How often you find the bug depends on how hard you look. It is possible to do a pre-enrichment for Campylobacter in a broth before you plate them out. Which other organism do we use a system of pre-enrichment? So which other bug that causes gastroenteritis do we look for by using pre-enrichment? And what's it called, this pre-enrichment? You're all brain dead. Or you're all just scared to say anything in case you say something wrong. Yeah, we use selenite broth to pre-enrich for salmonella. What that means is the poo comes in, into the broth, 24 hours, it grows and becomes abundant, other bugs don't grow, and then you put it on your plate for 24 hours. In this case, you would go broth for Campylobacter, in goes a bit of fecal material, 24 hours to enrich, then onto your plate for 48 hours. It will extend the time for your culture from 48 to 72 hours by doing that 1 day pre-enrichment, but it would raise your yield a lot because bugs always grow better in broth. If you're a bug and you want to grow, please put me in broth. Why is broth better than a plate? They've got media all around them, much better absorption of nutrients, much faster growth. I would say if you use a pre-enrichment for a broth, you would increase your rate of isolation by maybe 10%. Now, that's not a lot, and it may be that 10% is not worth the effort. Cost, extra time. You know, whenever you go out by a day in your reporting of a result, it becomes less relevant to the clinician. So there's a trade-off between being quick and being sensitive. How about filtration? Now, some of the media that we use contains antibiotics that inhibit Campylobacters other than Jejuni. Let me say this again a bit more clearly. So there are 3 types of Campylobacter that we see in humans. The most common by a long way is Jejuni. We sometimes see coli and sometimes see Upsaliensis. In most media, we contain some cephalosporins, some antibiotics. And the cephalosporins work because they inhibit most other gram-negative rods, but don't inhibit C. jejuni. In other words, the cephalosporins are selective for C. jejuni. Straightforward. Unfortunately, C. coli and C. upsaliensis are also inhibited by the cephalosporin. So on most culture media, by definition, you will not grow C. coli and you will not grow C. upsaliensis. But because jejuni is the most common by a long way, nobody really cares. Doesn't matter. Unless you live somewhere where coli and upsaliensis are more common than just not very common. Well, how would you ever know? If you can't grow the bugs, how do you know how common they are? Well, you don't, unless you do a survey. So there is one method that grows all Campylobacters equally well. It's called the filtration method. You take a 0.45 micron filter. Is it 0.4 or 4? How big is a red cell? How big is a red cell? You must know how big a red cell is. What, 20 microns? 200? I'm going to tell Jane you don't know how big a red cell is. You must be brain dead. How big's a red cell? 8 microns. Thank you, hallelujah. So these filters are about half a micron. You put the filter on a plain blood agar plate and you take your poo in a bit of saline and put that on top of the filter. And because Campylobacters are very motile and they swim through the filter into the agar. And most other bugs are either non-motile or too slow or too fat. You're too slow and you're too fat. And you can't get through. So after about a couple of minutes, you pull the filter off and chuck it away. And all the campies that swam through onto the surface are still there. Incubate the plate, colonies, Bob's your uncle. Easy. It works well, except it has a requirement for a higher number of organisms to become positive than culture does. What that means is you can grow all of them, but you become a bit less sensitive at growing the common one. So there'll be some cases of jejuni that will be culture positive on a selective plate, but culture negative by filtration because they were there initially in small numbers. Does that make sense? Kelvin? You sure? You were daydreaming, weren't you? Your mum was somewhere else then. Your mum was on the golf course. I can see it in your eyes. But you aren't the only one. So, as a routine, you can either use just a platelet selective or use a platelet selective and use filtration. But you can't ever use just filtration. If you use just filtration, you win a bit by growing bugs you couldn't grow otherwise, but you lose a lot because of the most common bug you won't find as well. In Tasmania, over a whole year, doing a survey in Launceston, by using filtration as well as doing the culture with selective plates, they grew, I think, 10 more for the whole year. Wasn't worth it, so they don't do it anymore. But it's important to find out. So at least at some point you want to try and establish whether or not all your campies are jejuni, which means just use culture media which is selective, or a mix, which would mean doing both plates are selective and using filtration. Why isn't that working? Okay, so you've done your culturing and you've put your plates in the incubator and you pull them out. If your plate's this one, it's charcoal, so it'll be a black plate, and these are sort of used live blood They'll either be brown or they'll be red. Doesn't really matter. The morphology is the same in all of them. Seeing growth on the plate is already strongly suggestive of Campylobacter because not much else grows. Seeing growth and the bug being oxidase positive is very good because Campys are always oxidase positive. There is one bug which can be irritating because it grows on the plates quite often and is also oxidase positive. And that bug would be, just think about what property would a bug have to grow on a Campy plate. It would have to be a bug which was strongly antibiotic resistant, wouldn't it? Because the plates are selected with antibiotics. What bug do we know that hangs around the bow, gram-negative, right oxidase positive? Pseudomonas. The good thing is Pseudomonas have different morphology on the plate. Most Campys, they're smallish colonies that often spread, but not in the same way as a Pseudomonas colony spreads. So Pseudomonas is a streak line. It spreads in the crinkly sort of edge like this. But a Campy is sort of juicy like this, that spreads. And they're wet sort of colonies. The best way to confirm that your colony is a Campylobacter is to do what? Do a gram stain. Pretty quick, pretty cheap. So what I do is, yep, colony. It might be Campy. Oxidase test, negative. Not Campy. Chuck it out. Oxidase pos, might be Campy. Gram stain, curved rod, Campy. Done. If all you do is a gram stain and an oxidase test, the best thing to do is report that as a Campylobacter species. All you've proven is that it's that species. Because Jejuni is the most common cause of gastroenteritis in Australia, and because it's the only one that grows on those plates, it's not unreasonable if you want to call it Jejuni. But you haven't proven it. It's suggestive only. But people do that. If you want to go a bit further and you're using methods other than a selective plate, then coli and the others might now be in the mix. And you can do other tests. You can do a test for sensitivity to nalidic acid, and you can do a test for hippurate hydrolysis that will separate Jejuni, coli, Upsalensis, and a few others that are, funny animal ones. For most routine laboratories, all you do is a gram stain and an oxidase. Because to do more than that costs you more money, slows you down, and gives no more information to anybody. So why would you bother? It just seems a lot of time that we waste and money we waste being smart asses that doesn't help anybody. So going as far as there is probably perfectly okay. On a scale of 1 to 10, the content of this slide is a 1. Just so you know, we'll talk about it for about 5 minutes or less, and then we'll move on. It's most unlikely I'd put this on the exam, because to me, I want you to study things that are important for your profession that you see all the time, not spend your time worrying about things that you might see once in a lifetime. So, Yersinia enterocolitica can cause gastroenteritis. It's very, very uncommon in Australia. Now, it may be more common elsewhere, I don't know. I've only ever really worked here. The most common animal that carries the bug is a pig, and that might be half the reason why it's less common in Australia. We don't, not big pork eaters compared to what we eat chicken, lamb and beef. It's psychotropic, so it grows well in the cold. So it will grow even if the food's in the fridge. It grows slowly, it doesn't grow beautifully, but it grows in the fridge. Only about 5 out of 50 known serotypes can cause disease. I think you can serotype them. we'll come back to mesenteric adenitis in a minute. But for routine isolation, because this bug is a coliform, just a coliform, like E. coli but different, you need some kind of technique to make this stand out from your culture. So you use a plate which is selective and a little bit differential. It is called a CIN plate. CIN stands for cefsiolodin, which is an antibiotic, ergosan, and novabiocin. And these are all things to make the plate selective. And supposedly on this plate, if you grow a Yersinia, what you get is what's called a bullseye colony. Not the same as enterococci, which are small bullseyes. These are big bullseyes. They're light pink with a darker pink centre. And because they grow well in the cold, if you grow these things at room temperature, most other coliforms won't grow. So it makes your plate more selective, but then it's also slower. So it will take 2 to 3 days to get good growth on this plate from store specimens. And when you do your test, your API, whatever else you want to do, you do them also at room temperature. I have tried in our pracs, I've got 4 or 5 type strains of Yersinia that I got from somebody in Melbourne. And in the pracs, when I grow this bug, and I try and grow E. coli or Citrobacter, what I get on the plate is the same growth and the same appearance. I have never ever grown a Yersinia in Australia. I've spent 20 years before I came here culturing for the bug every single day. Never grew one. And so many times I'd grow a bug that was, yeah, it's a bullseye, do an API, E. coli, API, Citrobacter. And what happens is after a while, if the plates that you have are selective and differential, let you down, so that you pick something off which you swear is positive, do an ID and it comes back negative, in the end you lose faith with the media and you stop trying very hard. So I think that CIN is not a good medium. It doesn't work that well. It's not very selective and not very differential. Certainly in my hands it's not been very good. So the rate of isolation in Australia is very, very low. Now that may be because the bug is uncommon. Or it may be because our techniques at finding it are not very good. And once the techniques aren't very good, we stop looking for it. So right now in Australia, it's a very, very uncommonly reported organism. The only time I might want to look more carefully is a disease called mesenteric adenitis. And what happens is this bug is ingested and it invades the lymph nodes around your appendix. And they get inflamed and you get pain there, and the pain is indistinguishable from appendicitis. And they pull the appendix out, and often you'll get that for culture. What I would do then is try and culture that in a cold broth, because the bug's psychotropic, and then put it on CIN media, because if I can grow the organism from that situation, it's got a much higher chance of being positive. Other than that, this bug to me, it's not a big player in terms of what we look for routinely in Australia anyway. Right, what we'll do is have a break, because this is going to be a long session with this organism. It's 10 to now by my watch. Come back at 10 o'clock. And try and come back awake. Right, using the same scoring system as before, the content now is a 10 out of 10. I can guarantee you this will be on the exam. It's heavily examined every year, and it will be this year. It's very important. It's a very common organism, causes lots of disease, and it's nasty. And the way the labs handle it can be quite complicated, so you must study this. And if I have this in the exam and you fail this question after I've told you this, you deserve all you get. no sympathy at all. This is important. So, Clostridium difficile as a cause of diarrhoea has become much, much more important over the last 20 years than ever before. And as we talk about how the bug causes disease, it might become apparent as to why it's become so important. So the bug is an anaerobic gram-positive rod. It's a spore former. It forms spores. And spores are really hard to get rid of. Once the spores are there, pretty hard to remove them. It tends to cause disease in people who either are currently having or have had in the last couple of months some antibiotic therapy, which is lots of people, by the way. And what you tend to see is that the bug must be there in the environment, and we must be exposed to it on a fairly regular basis, but only when exposure happens to coincide with the right conditions, that is, we're vulnerable from antibiotic therapy, do we get disease. Lots of factors are involved about how we're exposed and when we're exposed, and when exposure causes disease versus not disease. It's very complicated. You can't just say, overexposure plus antibiotics is disease. It's not that simple. But exposure is probably more common than we think, and disease happens to only occur when a whole set of other conditions are met. Sorry, Hedron, you went back. Nevertheless, the more often you're exposed, the higher your risk. Makes sense. And the more often you're exposed when you're having antibiotics, the higher your risk. Again, it makes sense. Because people who are in healthcare institutions have a lot more antibiotic therapy than anybody else, by definition of their health status, we see this disease more commonly in hospitals and aged care facilities than anywhere else. But the disease does occur in the community because it's possibly exposed in the community and it's possible to have antibiotics in the community. We all do. But it's a more common disease in hospitalised patients, but not unique to them. As a disease, it can range from being very, very mild diarrhoea to severe diarrhoea with pus and blood, to the most severe kind of disease, which is called pseudomembranous colitis. And in pseudomembranous colitis, what you get is lots of ulceration of the epithelium in the colon, and the ulceration then bleeds, and sometimes whole chunks of the epithelium fall off. It's called the membrane, the pseudomembranous colitis. So you have inflamed colon, pus, blood, lots of pain. As a disease, we know that this bug commonly makes two toxins. Toxin A is an enterotoxin. In other words, it makes you have runny poo. Toxin B is a cytotoxin. It kills the cells in the colon. Both toxins play a role in disease, and most strains make both toxins. But there are a number of well-known strains that are toxin A negative, but toxin B positive, and they still cause disease. It's very hard to try and sort of say, oh, look, disease by toxin A negative ones is not as bad as ones are toxin A positive, because the disease itself is so variable in how it presents depending on the person. So unless you have some way to isolate all those other variables, you can't really attribute disease severity as to whether or not you make toxin A and B or just toxin B. Most strains make both toxins. Sometimes one will make just toxin B. It's only important in terms of diagnostic approach. It's not really important in terms of the patient's status and their treatment. No one goes, aha, this one's only a toxin A negative, we'll do this differently with the patient. Nothing to do with it at all. it's important for how we diagnose them, and that'll become clearer in a minute. There are a number of strains, lots of them, that make no toxins at all. If the bug makes no toxins, there is no disease. It's a non-event. That means that just finding the bug by itself is not enough to diagnose disease, because if the bug's there but can't make toxin, doesn't matter. That's a disease of bug making toxin, not just the bug being there. This is, severe disease, and this is looking inside somebody's bowel. The bowel should be lovely and pale pink, not this angry, bloody pale pink with all those pustules there. That's end-stage severe disease, at the end of the spectrum. But you understand what I'm saying about it being a severe disease. If that was your bowel, you wouldn't be having much fun right now. You'd be in a bit of pain. Always the question is, when do you look for certain organisms in a stool specimen? Is Clostridium difficile a bug you look for all the time? Well, that depends on where you work and what your patient cohort is. This bug should be compulsory to look for in every stool specimen of any patient in hospital. It's just a no-brainer. This is a bug that you see causing disease in hospitalised patients. Therefore, look for this in every patient. But some labs still won't do that because it's costly. They might say, well, if an inpatient who's been in hospital for more than a week, we'll look for it, but not in the first week. And if you're an outpatient who's had some antibiotic therapy in the last couple of months, that's not a bad indicator for possibility of being C. difficile. But some labs say, oh, I look for C. difficile only if the poo is bloody. That's not a bad way either, but the trouble is lots of patients can be positive, but at the time of presentation their stool isn't bloody. So there's an unknown answer to that question. Where you work will have their own set of rules about when you do and don't look for this organism. It may be in every patient. It may be only in some patients depending on prior conditions being met. That is, prior antibiotic therapy, bloody stool, hospitalised patients. All those rules, they have flaws in them. I mean, so far for you, you've not seen a request form from a clinician. Most times all you get on a request form is poo, diarrhoea. It doesn't say, oh, poo, please look for this, that and the other. By the way, return traveller from Vietnam, eats a lot of seafood and has had antibiotic therapy in the last 2 weeks. That information is kept back somewhere else. You don't get the information. So you're limited by what you can do in terms of screening the patient on their history, because you don't get the history. Okay. So we understand that how we diagnose them depends on what information we have and where we work. Now, once you decide, yes, I will look for C. difficile, even that decision there is difficult. Once you decide, yes, I'll look, the number of tests available for C. difficile are like this big. And they're different cost, different sensitivity, and different reasons why you would apply them. So I'll go through a range of tests that we do and try and talk about the pros and the cons, and then I'll try and draw you a bit of a flow chart that might put it in the context, but it's a bit tricky. So you can do culture. Take the poo, get a plate, and try and grow C. difficile. The plate must be selective because there are lots of things in poo that are not C. difficile. So we use a plate called CCFA, which is cycloserine, cafoxetin, fructose agar. And the cycloserine and cafoxetin are things that make the plate selective. and the fructose is differential. C. difficile goes a little bit red on the plate. Now the plate itself is a yellow plate made of a base of egg yolk. And the culture technique, the plate says a positive culture smells like horse manure. It's got a very horsey, uriny, stale horse poo, stable sort of smell. And it's quite distinctive. And the collie should be a little bit red. To make that plate a bit better, you can pre-select by doing alcohol shock. What that does is you put your stool in some alcohol for 30-40 seconds, and the alcohol kills all the cells that are not spores. But because C. difficile makes spores, it'll survive the pre-treatment and makes your plate more selective. Or you may do a pre-enrichment with a broth that's selective and then put it on your plate. So even now you can see with just one thing, culture, there are variables about what you do depending on where you work, so it's not straightforward. So you've done all those things, you've chosen one method or the other, and you've grown something, and it's positive. You've proven your colony is C. difficile. And you can buy a kit that will test that colony like a agglutination test for cariculase. Colony, right colour, right smell, on a slide, mix, agglutination, C. difficile. The test is very sensitive, but you may have grown a strain that can't make toxin. And these are quite common, especially in children. So you must now prove that either that bug can make toxin, or you go back to the stool directly and look in the stool for toxin. And most times at this point you test for toxin B, the cytotoxin. So culture alone is sensitive but not specific. If you combine culture with a test for toxin production, we call that toxigenic culture. And that is very sensitive and very specific. But it'll take you 2 days to grow the bug, a day to prove it what it is, and then at least a day to prove it's got a toxin. There's 4 days. 4 days, labour intensive, requires quite a bit of skill. Great test, but done really by big labs that are reference laboratories, not routine at all. Got to be a better way. It's also possible to do a test called the GDH latex test. And the GDH is a test for, I think this is right, glutamate dehydrogenase. Now this test is a test you do on a stool specimen, and it's made of latex particles with a glutamate. Simple process. When the test was first developed and marketed, it was marketed as a test for C. difficile antigen. And then somebody did some specialised work and proved that the target of the antibody on the latex was not for C. difficile surface molecules at all, but for an enzyme that's most commonly made by C. difficile. So the GDH is an indirect marker of C. difficile. You are detecting GDH and then saying, oh, if the poo is positive for GDH, it's probably come from C. difficile. But a number of other anaerobes also make GDH. And the GDH is made by strains that are toxin pos and toxin neg. So the GDH is not a bad test. It's quite sensitive, but it's very non-specific. So labs often use the GDH screen and say if it's negative for GDH, it's probably not C. difficile. Negative test, report negative, end of story. Positive test means I can't exclude C. difficile, I'll do something else. So a negative GDH means done deal, finished. A positive GDH means more work to do because a GDH tells you that possibly there's C. difficile in the poo, but it won't tell you for sure if it is or isn't. And if it is, it won't tell you whether the bug makes toxin or no toxin. So GDH, good, cheap screen. Takes half an hour compared to doing culture, which takes you 4 days to get the final answer. So GDH, very good, quick screen. Labs always want better ways that are more cost efficient and faster. And you'll find now we've moved away from doing culturing to doing non-culture tests. This test, called the cytotoxin cell culture assay, is the absolute long-standing gold standard test for C. difficile disease. Every other test is compared to this one in evaluation. Again, this is a test not done very often because it's demanding and it's expensive, but it's the best. This test takes poo directly and looks for the presence of biologically active toxin B, the cytotoxin. It has an incredibly low level of detection. It's able to detect picogram amounts of toxin. What's a picogram? Is it 10 to the minus 6, 10 to the minus 12, 10 to the minus 12? So an incredibly small amount of toxin is a positive test. The way you do the test is this. You take a cell culture, which is your reagent. These are living cells in a cell culture flask. And you add some poo to the cell culture flask and you incubate. If it's positive, the toxin, which is a cytotoxin, kills the cells and they go all rounded. Healthy cells, unhealthy cells. Because it's possible for things other than toxin to make the cells go funny, like a smelly poo that's just got stuff in it, you run a control. And the control will be the poo specimen plus a specific antitoxin. And that means if the rounding of the cells is caused by the toxin, in your control test with poo and antitoxin, nothing happens. You must do a control. So already you're seeing, wow, I've got to have this cell culture always on standby, and these cells die in 4 or 5 days. So it means even with doing no test at all, I've got to maintain these cells in a live state in my little plate of cells. And I might have to maintain 4 or 5 plates of cells every day in case a specimen comes in. So it's costly. Even with no specimens at all, you're spending money on the test. And you've got to buy in some antitoxin, do the test twice, with toxin, without antitoxin. It's hard work, it's expensive, but it's very, very good. There's got to be a better way. And there is a better way. There are a whole pile of tests that will detect the toxin by immunoassay. Now the test with cell culture tests for the toxin by its activity. ELISA's test for toxin by its presence, because you get an antibody that binds to it and you get an endpoint, either agglutination or with EIA, a colour change that you've read by a machine. Are you all okay with EIA tests, ELISA tests from immunology? Please say yes, you are. It's possible to buy ELISAs for C. difficile that target toxin A or toxin B or both. Given that we know that there are some strains that make toxin B only and are toxin A negative, if you choose a test for toxin A only, you're mad. It's better to have either toxin B by itself or both in your tests. As always with ELISAs, these tests are very good, but they require quite a lot of toxin to be present to get an endpoint in your reaction. So where the test for cytotoxin in cell culture can detect a picogram amount, this would be at least 1,000 times less sensitive in terms of limit of detection. It would need amounts in the microgram range, not the picogram range. It's not as good. And you'll find if you compare these tests with this one, this is a test for cytotoxin with the cell culture system. Most times when this is positive, they're both positive. That's what you expect to see. And most times if this is negative, the gold standard, they're negative. But in amongst that evaluation, there are some times when that's positive, but one of them is negative. Or that's pos and they're both negative. Or they're neg and these are false positives. So the tests aren't perfect, but they are very commonly used. Please don't ever assume this. Oh, I bought a kit commercially, it must be good. Because it's not true. Lots of kits you buy might be quite good in one context, but bad in your context. Or some kits are just crap completely in every context. But the companies spend lots of money developing the test. If it's crap, they don't go, oh, this is a crap test, I won't sell it. They sell it to get their money back. Not all kits you buy commercially are good kits. And most big labs do an evaluation before they use a kit and put in a routine use. Small labs don't. They rely on literature or other labs to advise them what to do. So you'll see here, those tests, they're pretty good. Most times, out of all those 400 odd specimens, so out of 446 specimens, most times the answers are the same. A small number of times the answer is different. But for most purposes, they're pretty good. In this slide, it's just a table that shows you a whole range of different kinds of approaches for diagnosing C. difficile disease. And we haven't yet talked about PCR. And it's kind of hard to imagine these days that PCR isn't the best way of doing it. But it isn't, because PCR is great in the right specimen, but stool specimens have lots of inhibitors of PCR reactions. So doing PCR on stool can be quite challenging. It doesn't always work. So we can get PCR to look for the toxin genes, but it's not yet the best method. So a whole range of tests are available. So let's have a quick recap of that. Before I do, and we'll talk more about this in a minute, but you know, idea of the cost. Now these numbers are quite old, but this one up here is good because it's quite local. So this is Perth, WA, and they did a survey over a whole year of 37,000 patients. They had 90 who were pos for C. difficile. They compared their length of stay, if you were positive, with length of stay for similar patients who were negative. Average stay for a control patient was 6 days. If you got C. difficile diarrhoea, your length of stay went up to 21 days. Length of stay in hospital is the biggest cost factor there is. An average bed day costs the government how much, roughly? Every day you're in hospital, the government's going to pay, what, $100? Yeah, about $1,200, at least over $1,000. It's a massive amount of money. So this is old. This is, I mean, 27 years old data. $1.5 million just in that one disease. In Hobart, in 1999, in 1 year, 300 cases, cost Tasmania $3 million. So it's expensive disease because it keeps you there longer. What's the biggest risk to getting other kinds of infections in hospital? Like pneumonia, septicemia, UTIs. Biggest risk is how long you're there for. The longer you stay, the more risk you get. So getting C. difficile keeps you there longer, you're in the firing line for other diseases as well. So it's a horrible thing to have. So about 10 years ago, this was a great big study in America, and they did a study over one single day. It's called a point prevalence survey, a snapshot of the whole country on one given day. And they found 13 cases for every 1,000 hospitalised patients. And estimate from that, in one day in America, 7,000 cases and 300 deaths on one single day from one organism. That's massive. And what was even more telling was they were able to say that it occurs most often if you're over 60. I wonder why being over 60 is a risk. Other comorbidities, other things that put you in hospital. I mean, the chance of being in hospital is much higher if you are older than if you're younger. Makes sense? And we saw that 80% of those patients had antibiotic therapy in the last 30 days. It needn't be yesterday or today or last week, anytime in the last month. And not all drugs are equal. Some drugs are much more commonly involved in precipitating an infection with C. difficile. And the ones that are most commonly involved, cephalosporins. And which drugs do we most commonly prescribe? Cephalosporins. So it's commonly involved. If that wasn't bad enough, there is now a new strain of C. difficile which has emerged and spread globally. And depending on what you read, it's referred to by a number of different names. The NAP1 is called the North American phenotype 1. And the 027 is the ribotype. So with every single bug, there's a system of doing subtyping of some fingerprinting method. And we know this strain is different. First thing is, this strain's got a deletion in the gene that regulates the production of the other toxins. So this strain makes more of its toxins. And level of toxin production is known to be linked to more severe disease. It's made a new toxin called the binary toxin. So it makes more of the old toxins and a new one. Not nice. And it hypersporulates. So you're a patient in a ward in hospital and you're unlucky and you get C. difficile diarrhea. You're sick, you've got horrible diarrhea, and the bug you're pooing out makes spores. And when you die, or you get better and you go home, and your room is vacant, next day, in comes a new patient. And there's spores all over the room. That means new patients exposed. And the spores get out through currents of air in the room to the other wards, everywhere else. So there are now teams employed to go into that room and make the whole room decontaminated. But it's extremely expensive because it's hard to kill the spores. You can't autoclave a whole room. So you need to use very, very high-level sporicidal disinfectants. Having strains that hypersporulate makes that more difficult. It makes more spores. And if you think about C. difficile disease, most times the bug must be inherently resistant to the drugs that alter your bowel flora and allow it to cause disease. So if your strain of C. difficile has extra attributes that makes it resist more antibiotics, it's more dangerous because it can therefore hang around more often in more patients. And we can treat C. difficile disease with antibiotic therapy. If you have C. difficile diarrhoea, we can treat that with antibiotics. It doesn't always work, and there are other alternatives, but it's commonly treated with antibiotics. So this strain is pretty nasty. The biggest advance in treating C. difficile has been fecal replacement therapy. So give a person a poo transplant. They give them an enema with donor faeces to recolonise their bowel. It's now become a well-established, reliable technique. It's available in Australia, not everywhere, still done in specialist centres, but it is a reasonably good technique to use. So, in comes the poo. Your first question is whether or not you will screen for C. difficile. Your lab will have a policy. It will say, yes, every poo. Or it might say, yes, every poo of hospitalised patients, but no if they're outpatients. There'll be a rule that you apply, or a series of rules. But it won't be every poo. If you decide the answer is yes, then what do you do for a method? One approach is to do the GDH test. It's cheap and rapid, agglutination. If it's negative, goodbye, it's gone. If it's positive, you've got to do more. And what the more is depends on where you work. Now this is not all one lab, this is either or. You may choose, if you're a big laboratory, to do culture. If the culture is negative and you can't grow and isolate C. difficile, goodbye, negative, it's gone. Same as over there. If your culture is positive, you've got to do more. It may be that you're a big lab and you're very clever and you might want to do a test for cytotoxin using cell culture. It's the best method there is, but it's hard to do. If that's positive, you report that. If it's negative, goodbye. Or you might just do ELISA, EIA test for some kind of toxin, either toxin A or toxin B or toxin B or both. And if that's negative, it's goodbye. If it's positive, you report them. This approach will be less sensitive than that one and less than that one. Probably about the same as that one. The benefit here, though, is that a positive can be reported, whereas over there, a positive can't be reported. And it may be in your lab that these things are so cheap that a positive might mean I now jump to do that as a second test. There are so many combinations of how you combine these tests. You might say, I'll do this first. If it's positive, I'll do culture. You apply these things together depending on what you want to do and how much time you want to spend. There is one thing that you shouldn't be doing. Supposing you do an EIA, your negative test. We know these tests have got limited sensitivity, which means the NPV is not perfect. It's possible to be negative by EIA and it be a false negative. Some clinicians will do this, request an EIA, get a negative result, and they go, oh, I'm sure this patient's positive. Do it again. And they give you a new poo tomorrow, you do it again. New one tomorrow, next day, do it again. If you keep on doing this test over and over again, at some point you're going to get a false positive. So in the end, if you repeat this test over and over again, you won't so much raise the sensitivity as you'll decrease the specificity, and you'll end up with a false positive. You shouldn't be doing this test as a repeat test. You do the test and understand its limitations, but if you keep on doing it over and over and over again, you're not helping anybody. So we'll probably have an assignment on C. difficile because it's so important. I want you to make sure you learn this properly. Running out of time, talk too much. Right. Very quickly, there are a range of E. coli that cause diarrhoea. These three we'll talk about almost not at all. Very quickly. There are ones called EPECs, enteropathogenic E. coli. They cause disease occasionally, very hard to prove causation. You can only prove that your strain of E. coli is an EPEC by serotyping. That means getting a poo from a patient, culturing all the E. coli's and serotype them. Time consuming, expensive, very low yield, and even when you find a positive one, you can't prove a thing. So we know they exist, but forget it. Never routine. Some strains are ETECs. These are ones that make toxins, and the toxins are a bit like the cholera toxin. Again, we know they exist. There is no simple way by phenotype to prove whether a strain is or isn't one of these. It means growing the E. coli's and looking in their genome for the toxins with a probe or some PCR. Very expensive, very uncommon. Forget about it. It's not endemic, it's not routine. And there are some E. coli's that are invasive because they've got plasmids they've pinched from Shigella. In other words, these are E. coli's that are Shigella, but they're E. coli's. And very hard to find them. So this set of bugs, they exist, but you would never look for them routinely. But you heard it once. This one is really important because it causes a lot of disease. Now, same deal here. The range of disease you see from these strains of E. coli's, and these are called enterohemorrhagic E. coli, or sometimes called Shiga toxin producing E. coli's. And these bugs make a range of toxins and other attributes that make them cause disease. It can range from being diarrhea to diarrhea with blood to disease that extends beyond the bowel. And then you get the hemolytic uremic syndrome, where you have intravascular hemolysis and renal failure, and you end up with TTP, thrombocytopenic purpura. Is that right? For every infection you have, the diarrhea is reasonably common. There's a small risk of 5 to 10% of developing HUS. So most patients who are infected get diarrhea, but don't get HUS. And a small number of them that get HUS will get chronic renal failure and they might die. So death is not an uncommon outcome from infection, especially if you're young. Let's have a think about some numbers, just to put it into context. Here's a range of infections I've seen before and recorded. This is Japan in 1990. In a kindergarten, infection was by pre-prepared lunches, cases 400, deaths 2. In America, 93, cases 1,000, HUS 55, deaths 4. Scotland 96, cases 500, deaths 20. Japan 96, cases 18,000. This is from one outbreak. Hospitalisation was 2,000, deaths was 12. We've had one in Australia in 1994, 18 cases, 1 death. And, where's the numbers for that one? Oh, the big outbreak that occurred in 2011 in Spain, deaths 50, 1,000 hospitalisation, deaths 50, 3,000 hospitalised and 1,000 with HUS. This is a horrible organism that occurs in big outbreaks. Let's think about what makes this bug special. Well, the first thing it has is it has plasmids. And the plasmids give it adhesins that let it adhere to the cells. And these are similar to the plasmids that you see in Shigella. We also know that Shigella dysenteriae, the most severe Shigella, has a toxin, the Shiga toxin. And the toxin's encoded by a phage, a bacteriophage. And the phage has got out and is infecting some E. coli, and then these become E. coli with all the other attributes of Shigella dysenteriae. So the Shiga toxin from Shigella is the primary thing this bug does, but not the only thing. We can serotype E. coli. The very first strain of E. coli that had this toxin was O157H7. It occurred in America in the mid to late 80s, and it was found in a fast food outlet in hamburgers. Since then, there have been lots of other serotypes besides that one that have this plasmid and have this Shiga toxin on the phage. Because the things that make them virulent are mobile bits of DNA, this type of disease is not limited to one serotype. It gets around. So to obsess about one serotype is just stupid because we see it in other serotypes. Now, the one in Australia was caused by not that serotype. However, America still has an obsession with that serotype. And as far as I'm aware, at the moment, they still require that any beef that leaves Australia and goes to America is proven to be free of that serotype. They don't care about anything else, just that serotype. Which to me is a bit short-sighted, but that's the way they go. We find that lots of food is linked to this organism. Historically, it was ground beef. Ground beef means mincemeat. Why is ground beef much more of a risk than not ground beef? And it's like this. When you kill the cow to make your bit of beef, if you have contamination, it'll be on the surface of the meat, because meat is muscle, it's sterile. So a bit of steak covered in E. coli on the surface that's exposed, fry pan, psst, psst. Even raw steak, the middle is raw, but the outside is cooked. The bugs are dead, it's safe. But with mincemeat, you take this bit of steak and you mash it all up, and now the bugs are through the whole thing. So if you have a hamburger that's pink on the inside, that might contain organisms. This is a risk. So we see much more disease in ground beef products than we do in anything else. You've also seen disease now in a range of other foodstuffs. And the case in Australia was found in salami. How do we cure salami? Why is salami stable on the shelf? Because the pH of the salami is acidic, and the acidity of salami makes it a preserved meat. We have, by our farming methods, suddenly developed a way of recruiting strains of E. coli that are acid resistant. If you feed beef normal grass, then you have about 20 strains of E. coli per gram of poo that are randomly acid tolerant. If you feed cows grain for intensive farming for better output and better beef quality, no grass, just grain, then up to 20,000 per gram of E. coli are acid tolerant. So we bred E. coli to tolerate acid, which means salami is not safe, fruit juice isn't safe, because all those things rely on pH to make them safe. So there's a risk there. I don't know how long your memory is. So this was a big outbreak a number of years ago in Europe, and initially they thought from case control studies that the disease was caused by cucumbers from Spain. So the Spanish people threw away all their cucumbers. It cost them $20 million in lost agricultural production, and then they found out it wasn't that at all. It was German sprouts, and they were pissed off. Ended up being quite a nasty incident between the two countries about who was at fault. What made it worse is this E. coli, not only was it an EHEC with this sugar toxin and the plasmids, had a range of other attributes that made it even more dangerous. So it was a strong aggregator on your cells. It had other genes that made it resist common antibiotics. It was a nasty bit of work and a big, big outbreak. Oh, yep, good. So how do we diagnose and look for EHECs? It is not routine. You don't see sporadic cases, or you tend not to see sporadic cases of EHECs. They occur in outbreaks. At the moment, for export to America, we must have our beef free of EHECs to their satisfaction. And what we know is that the 0157H7 serotype of E. coli, the one that we know is an EHEC, this serotype does not ferment sorbitol. So you make a McConkey agar plate and you place lactose with sorbitol and look on the plate for non-sorbitol fermenters. And all the ones that can't ferment sorbitol might be EHECs. But the ones that can ferment sorbitol can't be 0157H7. So if there's no orange colonies, it's done deal. It means 0157H7 is not there. If they're orange colonies, you then serotype them. If they're positive for this serotype, you report them. If they're negative, they're not there. The problem is, as an approach, it sucks because there are so many other serotypes that can have this property of causing disease besides 0157H7. It's a short-sighted and very inefficient policy. But that's what they demand that we do. To diagnose disease, forget about export quality, for diagnosing disease in a person, what you want to do is try and detect the toxin. Do a test for sugar toxin. It's very hard. It involves getting a rabbit, cutting the bowel out of the rabbit, doing an in vitro bowel assay. You wouldn't do one. So you do a PCR for the gene. Expensive. Are there any markers that you tend to associate with the presence of this toxin that are easier to pick up? And there is one. For reasons I don't understand, and I've looked hard to try and find a reason, strains that have this toxin tend to also have an enterohemolysin. They are not linked. There's an association. The enterohemolysin means if you screen these plates on a specific kind of blood agar plate, if they have hemolysis, they might be a EHECs. If there's no hemolysis, they're not. It's a very, very indirect measure. And %90 of strains that have this gene make hemolysis on this plate, and only 10% of strains that have not got this toxin hemolyse. It's not a bad screen, but it's not foolproof. And the screen uses washed red blood cells from sheep as the method. You buy them commercially, you don't make your own. Okay, last overhead we'll do in the first 5 minutes of the prac. Before the prac, make sure please you read through the pre-lab, and we'll go through the test as well in the prac. Okay, see you Wednesday.